This presentation is entitled Sertraline Therapy, Treating Depression. An integrative collaboration provides optimal therapeutic benefits while minimizing adverse events. This presentation is being presented by Curtis King, Doctor of Behavioral Health candidate at Cummings Graduate Institute for Behavioral Health. The content of this presentation will be more focused on the patient who is 60 years or older and who is prescribed sertraline, wanting to look at the indications of its use, the medication safety, alternative interventions, appropriateness of prescriptions, and medication monitoring, all of which are very important in order for that particular population of patients to certainly have the best outcome possible with treating their mental illness along with their medical illness. Sertraline and its use is primarily indicated for major depression or major depressive disorder, obsessive compulsive disorder, panic disorder, post-traumatic stress disorder, premenstrual dysphoric disorder, and social anxiety disorder. But the focus with the patient who is 60 years and older, who are considered experiencing late life depression, has a different presentation of symptoms than do the younger adults who are prescribed this medication. It is important for the healthcare provider to do a thorough comprehensive assessment before diagnosing and prescribing medications for this particular population. There are off-label indications for the use of sertraline, which is left up to the discretion of the prescribing provider. Dosing for late life depression, those patients 60 years and older, it's recommended 25 milligrams, which is the lowest dose of sertraline therapy. This antidepressant is a first-line choice to treatment of depression symptoms, primarily for its lower risks of side effects. However, there's a correlation between patients experiencing late life depression and comorbidity, where the metabolism of the polypharmacy effect, both the medical conditions and depression, has a bidirectional impact. The pharmacotherapy studies specifically on late life depression has focused mainly on inadequate dosage and length of time of treatment with a particular antidepressant, in part primarily because of the chronic condition of either comorbidity or multi-morbidity, which then reduces the effectiveness of sertraline when it's compared to other populations. Toxicity. Toxicity for sertraline is generally well tolerated. However, sertraline toxicity may result in serotonin syndrome. And the results of serotonin syndrome in terms of effects is myoclonus, muscle rigidity, diaphoresis, tremors, hyperreflexia, agitation, delirium, and then hyperthermia. Um, Certainly, the serotonin syndrome will require discontinuing the medication and looking at other alternatives than for treating this depression. Withdrawal symptoms. Any discontinuation of sertraline may cause some serious adverse reactions, particularly when it's discontinued abruptly. Those symptoms of nausea, diaphoresis, a dysphoric mood, irritability, agitation, vertigo, and even some sensory disturbances, tremors, anxiety, confusion, cephalgia, lethargy, emotional lability, sleeping disorder, hypomania, and seizures. Alternative intervention. Non-pharmacological intervention in this particular presentation consists of psychotherapy. Psychotherapy has been overlooked for its role in primary treatment of depression and an intervention for late life depression. It was found that 0.2% of late life depression patients were referred to individual therapy, even though sertraline and other drugs in its class were primarily prescribed 63% of the time by primary care providers. In those findings, it had shown that non-pharmacological interventions are a primary intervention and equally effective and preferred by patients with mild to moderate late life depression. In an integrated healthcare model, the behavioral health consultant, one of the roles that will be performed is doing a comprehensive biopsychosocial assessment and a depression assessment in order that a proper diagnosis can be certainly determined. Certainly assisting with, in collaboration with the primary care provider in terms of providing the right appropriate medication. Psychotherapy or the talk therapy, two different modalities have been proven to be the most effective with late life depression patients. Cognitive behavioral therapy, which helps the patient to identify and change unhelpful thoughts and thought patterns and behaviors, and problem solving therapy, which helps the patient to identify what the problem is and then helping the patient to define what the patient wants to achieve or improve. Healthcare providers who often prescribe sertraline will include the primary care physician, psychiatrist, nurse practitioner, and I will add to this one a clinical pharmacist, all functioning as an interprofessional team. This healthcare team members must follow the patient regularly to monitor the reduction of symptoms or any adverse effect. All of these providers should know the medication's contraindications, adverse effects, and interactions with other drugs. It is also essential to educate all the patients who are prescribed sertraline, especially patients 60 and older, on the possible adverse effects and the prevention and recognition of toxicity due to sertraline. Patient education regarding medication use and compliance will improve certainly the outcomes and ensure patient safety. Clinicians require vigilance regarding toxic effects of serotonin to ensure not to prescribe multiple medications that can cause serotonin syndrome. This is possible by preventing polypharmacy and minimizing unnecessary use of these drugs. Furthermore, patients need to be switched to a different serotonergic medication. The providers and other healthcare team members must ensure that no new medication starts until at least 2 weeks after the discontinuation of sertraline. Medication monitoring. The late life depression population is faced with multiple complex medical conditions requiring medication monitoring for medication optimization and solutions to improve the adverse effects of drug-drug interactions in the treatment of late life depression. It is essential then to monitor patients for unusual changes in behavior, anxiety, suicidality, or any other clinical signs of worsening illness. Regularly evaluate for depression and suicidality, especially when changing the dose of sertraline. Sertraline may also precipitate mania in patients at risk with bipolar disorder. So monitoring for symptoms of mania in patients who are started on sertraline is especially important if they have a family history of mania or bipolar disorder. Monitoring for abnormal bleeding, adverse effects of medication use, or withdrawal symptoms from abrupt discontinuation in the patient's taking of sertraline is something to give a watchful eye to. The abnormal bleeding may primarily occur if used concurrently with aspirin, NSAIDs, warfarin, or other anticoagulants. Sertraline may impair platelet aggregation and then cause bruising, epistaxis, or hemorrhage. Especially patients 60 years and older. Monitoring for changes in mental status is very important. And also being able to check regularly their sodium concentration due to the risk of hypoatremia. Sertraline is considered safe and effective. However, with severe late life depression conditions, psychotherapy and pharmacotherapy intervention together will provide the best outcome for the late life depression patient.